The syndrome of inappropriate antidiuretic hormone is characterized by high levels of ADH in the absence of a normal physiologic stimuli for its release. So things like cancer cause an ectopic excretion of ADH by tumor cells. Oat cell adenocarcinomas of the lung, the duodenal, the pancreatic, leukemia or lymphomas, Hodgkin's, colon cancers, all those different kinds of cancers can cause an increase in the ADH level. Infectious pulmonary diseases can cause ectopic production by infected lung tissues, so bacterial pneumonia, COPD, tuberculosis, those kinds of causes. Postoperatively, if someone's had pituitary surgery, stored ADH is released. So following any surgery, fluid shifts that may occur, apparently related to volume changes. Psychiatric conditions such as antipsychotic or sedative hypnotic drugs can also cause some of these problems. Other drugs such as antihypertensives or thiazide diuretics, analgesias, cardiac drugs. Some antibiotics may stimulate ADH release or enhance the physiologic effect of ADH. Traumas, if somebody's had a skull fracture, a subdural hematoma, meningitis, all of those things can affect ADH levels as well. So what happens? An expansion of extracellular fluid volume results and a dilutional hyponatremia results. Hyponatremia acts to suppress renin and thus aldosterone secretion. This decreases distal tubule reabsorption of sodium. The absorption of water continues, though, because the posterior pituitary has become unresponsive. Blood volume increases, and the kidneys attempt to compensate for this by actively excreting sodium, and serum osmolality drops lower. So what do we see clinically? We see a lot of signs and symptoms of water imbalance. Neurologic symptoms are often the result of cerebral edema, water moving into the brain, and the lower the sodium level goes, the more serious those neurologic symptoms become. Sodium levels under 120 really scare us. Actual mortality rates can be as high as 50%. And if the patient is cachexic or has a history of alcohol abuse, then the rate can reach as high as 70%. Remember that osmolality is normally around 280. So in SIADH patients, it's often below 275. And their sodium drops, so that's often below 135. Their BUN might be normal, or it might be decreased. So how do we clinically diagnose if they're in SIADH? Well, we give them a water load test. This is when the patient receives a calculated volume of water based on their body weight. Then their urine volume and osmolality are measured for the next 4 to 5 hours. In a healthy person, more than 80% of the water they consume will be excreted in urine, and osmolality will fall during that time. In a patient with SIADH, less than 80% of the water is excreted, and the urine osmolality falls very little, if at all. The test should be performed after an overnight fast, and the patient should be kept in a supine position for its duration. An upright position can produce false readings by decreasing the glomerular filtration rate. So usually they're in an outpatient clinic when this happens, or perhaps, the outpatient testing area of a hospital. So how do we treat this? Well, we have to monitor infusions very carefully. If the sodium levels are raised too quickly, then these folks can have neurologic damage. Generally, serum sodium levels should not climb by more than 12 milliequivalents per liter per day. So we want to bring their sodium up rather slowly. Lasix tends to make urine more dilute and inhibits free water reabsorption, which may also interfere with the action of ADH on the collection tubules. Florinef, declamycin both reduce the reabsorption in the renal tubules due to ADH. Declamycin has a delayed onset, so we don't use that usually for acute episodes, but for those cancer patients it might be a good choice. Lithium impairs the response to ADH and results in a more dilute urine and an increase in serum sodium. Dilantin inhibits ADH secretion, but its effectiveness is somewhat questionable. We want to fluid restrict these patients to around at most 1,000 cc's a day. If they have mild to moderate hyponatremia, will be more severe, maybe 500 a day if they have a bigger problem. We try to say 50% of their fluid intake should happen during the daytime and 30% in the evening. They need to take their meds with meals, they need oral care, brushing their teeth and things like that, but not a lot of water to drink. When they're thirsty, we suggest that they'd suck on hard candies. We really have to be meticulous about monitoring their fluid intake and daily weights. They need to go on a high sodium, high protein diet, and they need to be checked regularly for neurochecks and breath sounds and things like that. These folks will need education on the cause, especially if they have one of those more obscure causes or it's coming from a cancer or something like that, so that they know how to live with this problem. Diabetes insipidus, or DI, is just the opposite problem. Like all the other endocrine problems we've talked about this week, one is a result of too much of the hormone, the other is a result of not enough. And so DI is the result of a lack of antidiuretic hormone. So what causes DI? Well, a variety of different things. Neurologically, often by disruption of the hypothalamus or pituitary gland, maybe due to a trauma, or maybe they had radiation for a brain tumor or a cranial surgery. If they have a nephrotic reason for DI, then they have problems with their renal tubules, and their renal tubules are not sensitive to ADH anymore. Might be because of renal failure, or maybe they have a family genetic problem. So what signs and symptoms will you see as a result of low ADH? Well, polyuria, large amounts of dilute urine. Polydipsia, these folks are very thirsty and drink lots of water. They can become dehydrated and hypernatremic quite easily. Even though they're hyperosmolar, their urine is dilute and has a low specific gravity. The most common reason for DI, or lack of antidiuretic hormone, is a head injury. A traumatic brain injury is often when we see this. So when ICP problems have resolved, then usually the DI resolves. They tend to go hand in hand. So how do we treat this? Well, primarily we treat the underlying problem, and once hopefully we get that fixed, then these other problems resolve. If we have to give something for it, then we tend to give DDAVP, or desmopressin acetate. It's a synthetic analog to the natural pituitary hormone ADH, and it tends to affect renal conservation of water in the same way. It's indicated as antidiuretic replacement therapy if they have central DI, if it's the result of perhaps a traumatic brain injury. It's good for the management of temporary polyuria and polydipsia following head trauma or surgeries in the pituitary region. It doesn't usually work, though, if they have a nephrotic problem that's causing their DI. It's contraindicated in patients with moderate to severe renal impairment and in individuals, obviously, with known hypersensitivity to the drug.